Hi, everybody. I'm Dr. Connor Kerns. I'm an associate professor at UBC and a registered clinical psychologist. And I'm going to be talking to you today about distinct expressions of anxiety and autism and why they matter. But I do just want to take a moment to put up my disclosures so you understand everybody who funded this research. And I'm going to particularly point out, I'm going to be talking to you today about an interview called the Anxiety Disorders Interview Schedule with an Autism Spectrum Addendum. And I have not received any money for this instrument yet, but it is hopefully going to be published this coming year to be made broadly available, at which point I would get some royalties. So I just wanted to put that out there. Because I am a professor at UBC and I also am lucky enough to live in beautiful Vancouver, I also wanted to personally acknowledge the land in which I'm presenting from today is traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people. And I wanted to note that as a department, UBC Psychology is committed to diversity, inclusion, and equity initiatives to try and right past wrongs that have been perpetuated by the field of psychology towards Indigenous people. Okay, so now to the talk. The majority of this talk will focus on the expression of anxiety disorders and how we differentiate anxiety disorders from the typical ebbs and flow of anxiety that you see normatively. Particularly, I'm going to focus on research that talks about youth, and that's where most of the research has been done to date, although this is thankfully shifting and starting to change. And before we got into the data, however, I wanted to take a moment to really talk with you about the challenges that are associated with anxiety for autistic individuals and why recognizing and addressing those challenges is such an important goal. And to do that, I thought I'd begin by using the words of actually autistic individuals, their caregivers, and providers to illustrate those challenges. In general, the talk is going to be centered around quotes pulled from qualitative research studies, which are studies that highlight the perspectives and accounts of autistic individuals and those who support them in order to illustrate key findings from the broader research literature and their implications. So that's just the general structure of the talk. Jennifer. Sometimes anxiety can build up on itself like a brick on an accelerator pedal. Whenever you make a mistake due to anxiety, you become more anxious. It's just something that keeps being in your head, and you can't get it out, and you can't focus on other things. Anxiety disorders differ from anxiety, which is an emotion that we all experience and which typically serves an adaptive function. Anxiety helps us stay safe, plan for the future, get things done. Anxiety disorders occur when this typically adaptive, informative, emotional system, instead of helping us navigate our lives, shuts us down, becomes all-encompassing. Anxiety disorders dominate and deplete our attention as opposed to adaptively directing it. Research suggests that anxiety disorders are associated with specific additional difficulties for autistic individuals, such as increased depression and self-injury, reduced quality of life, more sleep problems and gastrointestinal illness, a reduced willingness to initiate social interactions, and increased family stress. He shuts himself down and he goes to bed. He'll be in that room for 15 hours. Children can become so overwhelmed and depleted by their anxiety that they withdraw from the world for extended periods. A mother whose son has a severe dog phobia describes, "I am risk assessing where it is appropriate to go and what is safe. I'm a single parent, so I have to really think, where can we go, where can we manage, and what's safe? And as part of that assessment, I think, will there be any dogs? So every time I go out, I consider the difficulties that may arise to minimize the anxiety. Every trip out the door requires an accounting of risks, of feasibility, of safety." Anxiety disorders can make it hard not only for autistic individuals, but also for their families to navigate the world around them and to complete daily tasks. There's this parable of the little engine that could. It's a little engine that wills itself over a tall hillside carrying a very heavy train by saying, I think I can, I think I can, I think I can. What makes anxiety disorders particularly dangerous and debilitating is that when you have an anxiety disorder, you look at a challenge and you think, I can't. You not only have to deal with the hill, you have to deal with the doubt. There are many challenges in life, and this is likely particularly true for autistic individuals. Yet there is a distinction between the challenge itself and the psychological distress and suffering that often accompanies it and exacerbates it. Reducing anxiety is a way to remove that additional layer of difficulty and thus to make a huge difference in the lives of people on the spectrum. And we may not be able to take away all the challenges, but we can work on building resilience rather than suffering in the face of them. And I want to note that I view anxiety disorders as a problem with actually great promise. So across clinical trials, of which there are now over a dozen, we see that 58 to 71% of autistic youth will experience a remission of their primary anxiety disorder following a course of cognitive behavioral therapy. Both group and individual CBT programs have been supported. Tailored approaches, that is CBT programs that have been adapted to autistic youth, offer some advantages, but research is also clear that standard CBT can be of help. Moreover, the research base is growing and focusing on expanding access. So emerging work supports the efficacy of CBT for adults, behavioral and modified CBT approaches to treat anxiety in autistic youth with intellectual disabilities, of school-based and stepped care programs that are aiming to get interventions to people expediently and cost-effectively. And I also want to note that we should care about anxiety because being able to accurately detect and measure anxiety will likely be crucial to reduce variability in a number of constructs of interest in autism research, okay? We know that a lot of variables can often look at better understanding. The variables that we look at often contribute to better understanding the strengths, challenges, and underlying mechanisms of autism, that those variables can be influenced by the presence of anxiety disorders. So for example, anxiety disorders in individuals on and off the spectrum can be associated with increased repetitive behaviors, sensory sensitivities, differences in social motivation, approach, and skill, cognitive testing performance, and even differences in the size and function of various brain regions that are often studied in autism. As such, the ability to accurately measure the presence of anxiety disorders in autistic individuals may actually lend insight into notable variability observed in studies and constructs that are relevant to autism itself. Okay, but this is actually all prelude, because the main purpose of my talk today is to convince you that to address these challenges of anxiety and autism to be most effective, we must begin by better recognizing and understanding the diverse ways that anxiety is experienced and expressed by autistic individuals. So how we define and assess anxiety disorders in autistic individuals, how we draw the lines regarding what to conceptualize as autism versus anxiety, has huge implications for estimating the size and characteristics of this public health risk, and to identifying who's in need of and likely to benefit from available treatments. Yet the process of drawing those boundaries is not so simple. A mother describes, sometimes it's very difficult to understand whether it's an autistic behavior or whether it's a behavior caused by anxiety, or both. And my hunch is that most expert clinicians would tell you the exact same thing. There are several reasons why drawing the lines or making these distinctions is so challenging. One reason goes back to, again, how we differentiate adaptive anxiety from anxiety disorders. So part of how we do this is by evaluating how realistic or protective the individual's fears are. What we see in autism is many reasons why having more fears might actually make a lot of sense. So Richard, an autistic adult, discusses his social anxiety. He worries, does this person like me? This is a quintessential social anxiety fear. But Richard also recounts, others were not interested in me, the other children ignored me. Many times people on the spectrum are worried about social encounters because they should be worried. Because they are actively being bullied, or more subtly, politely, but still painfully excluded. In such cases, such worries may actually be protective. So this quote illustrates how important it is to think carefully about how realistic and adaptive a worry is before pathologizing it, right? And why this can get complicated quickly when autism is also in play. Other key reasons why differentiating anxiety disorders and autism can be challenging are the overlap of autism and anxiety symptoms, and the distinct ways that autistic individuals may experience and express anxiety. So this is a description of Donald. It's described by his father and printed as part of Leo Kanner's original characterization of autism in 1943. We brought him to a playground slide. When other children were sliding on it, he would not get about it. And when we put him to slide down it, he seemed horror-struck. The next morning, when nobody was present, however, he walked out, climbed the ladder, and slid down, and has slid down it frequently since, but slides only when no other child is present to join him. Donald's father uses the word horror-struck, right? But what exactly is Donald afraid of? Perhaps he's afraid that the other kids will tease or dislike him. Alternatively, perhaps Donald is not attuned to or concerned with his peers' judgments, but he does fear how unpredictable they are. Perhaps his worries arise from his struggles to know what they want and what they're going to do. Maybe he's not scared at all, but just distressed because they're getting in his way. This quote illustrates how social avoidance like Donald's might reflect a feature of autism, a symptom of anxiety, or some combination of the two. Here are some more recent illustrations. Audrey. I get anxious in social situations as I don't see emotions in people until they get to a 10, and then it's an explosion, and I don't know when it's going to happen. A parking lot can be terrifying because of all the headlights. A mother describes her son's anxiety around changes in routine. At the beginning of term, they drop the first period of the first day. M couldn't sleep that weekend. He has to bring the books in for that period, even though he doesn't have it. In all of these examples, we see features of autism highlighted. Social communication difficulties, sensory sensitivities, a desire for sameness. But we also see anxieties layered on top. It's not just that M refuses to accept a change in his routine, it's that he was worrying all weekend, unable to sleep because he knew it was coming. A growing body of research is exploring the possibility that anxiety may come in many different varieties in autism, both similar and distinct from the anxieties experienced by autistic youth or non-autistic youth. And it's our working hypothesis that distinct expressions may reflect anxiety influenced by the different ways that autistic individuals perceive and experience the world. So across several research studies now, we've endeavored to carefully characterize anxiety disorders in autistic youth using an adapted clinical interview to reliably differentiate between autism and anxiety-related behaviors and to capture these distinct expressions of anxiety so that we can learn more about them. What we see in these studies is 30 to 40% of autistic children don't meet criteria for any anxiety disorder. This is important, okay? Because sometimes it can be really easy to think that all kids on the spectrum have anxiety disorders, but that is not the case, okay? And consistently in studies, we see 30 to 40% really do not meet full criteria. Okay. about 50% of autistic youth that have traditional anxiety disorders, so kind of these classic fears, things that you'd find in the DSM. Anxiety disorders similar to those that we see in autistic youth and cataloged by the DSM. 50% of those kids have traditional anxiety disorders, and 50% or more of kids with the traditional anxiety disorders like that also have impairing distinct anxieties. That is, for a third of autistic kids, traditional and distinct anxieties coexist. Finally, across these studies, we see that 15 to 17% of autistic youth have only distinct anxiety presentations. So that means, depending on how we want to characterize those distinct fears, as autism or anxiety, it could change our estimate of the prevalence of anxiety disorder in autism by up to 17%. And I'm going to take a few slides and moments now just to dig in a little bit deeper into what do we mean by traditional or DSM-defined anxiety disorders versus these distinct presentations. So how we're defining traditional anxiety disorders in these studies, these reflect anxiety disorders that are defined by the DSM and which meet full diagnostic criteria as outlined by the DSM. That is, they present in a similar manner in children on the spectrum as they do in autistic or non-autistic children. And those disorders typically include generalized anxiety disorders, social anxiety disorder, separation anxiety disorder, specific phobias, and panic disorder. Though notably, panic disorder is much less common in children, so you'll see there's really a dearth of research on panic. It's not mentioned in many studies, and it's not something we typically see just because so much of this research has been focused on children. Okay? So generalized anxiety disorder. This is kind of kids who have a worry du jour. If they're not worrying about one thing, they're worrying about another. It can sometimes be whack-a-mole. You take care of one worry, and another pops up. Kids with generalized anxiety are often worrying about how well they're doing at school, if they're going to get in trouble, make a mistake, might worry about politics, global warming, although I bet many of us are worrying about that nowadays, getting sick, if people are unhappy with them, if they're a good enough friend, kind of just being good enough in general is a classic generalized anxiety concern. And generalized anxiety is often associated with a lot of somatic symptoms, difficulties paying attention, trouble sleeping, muscle aches, headaches, because the worry is constant. Sometimes kids with generalized anxiety might be worrying all day at school and kind of hold it together, and then they get home and they explode, okay? Because they were working real hard to be perfect all day long, and then they kind of unravel when they get into a more comfortable environment, or they're exhausted. Social anxiety disorder. So social anxiety disorder is classically centered around this idea that you're afraid of other people rejecting you, embarrassing yourself, or being kind of laughed at or pushed out by others, right? So it's very much so centered around a fear of negative evaluation. Now, what goes along with that can be fear of public speaking, shaking around other people, but also just being afraid to talk to people in general, raise your hand in class, start a conversation, let people get to really know you. And often social anxiety disorder is associated with a lot of social avoidance. So kids don't want to go to do certain things because there might be other people there and they might make a mistake in front of other people. It can sometimes be difficult to parse out generalized anxiety and social anxiety. But a nice way to think about this, in kids with generalized anxiety, they're usually worried about failing their own internal standard about what they're supposed to do. And that will stay with them whether they're with other people or not. Whereas kids who are mostly socially anxious would usually be quite relieved if you took them out of the social situation. So they're very concerned about what other people might think about them, even more so than their opinion of themselves. Social anxiety, very focused traditionally around this fear of negative evaluation, which again, we can very much see in some folks on the spectrum, but for other children on the spectrum may not be as present, right? It may not actually be something that they're thinking about as much. And in those cases, when we're seeing anxiety in social situations, we have to think carefully about whether this diagnosis of social anxiety disorder truly fits. Okay. Separation anxiety disorder. Okay. A lot of kids with separation anxiety disorder, you see it first behaviorally. They get tummy aches and headaches when it's time to go to school or it's time for a parent to go away. They can get teary, ask a lot of questions, not want to leave the parent in any way, so not stay with the babysitter. It would be a problem even for parents to go out to run an errand because they want to be with them constantly. And usually the core fear in separation anxiety disorder is something bad is going to happen to my parent or to me if we're not together, and maybe I'll never see them again. Okay. It's something we typically see in younger children as opposed to teens. And sometimes you can get at that core fear, and sometimes it's quite hard, particularly in young kids. And what you see more is this behavioral avoidance of separation in any way. A lot of parents of kids with separation anxiety will say, oh, they're my little shadow, okay? Because the kids are always having an eye on their parents. They're even following them around the house. They might be a child who's even sitting outside the bathroom door when the parent is taking a shower or going to the bathroom. Also, often a lot of time, trouble sleeping alone is associated with separation. And finally, specific phobia. This can be anything from fear of rats, which I have, fear of dogs, snakes, bugs, needles, blood, loud sounds, heights. So specific phobias tend to be, at a subclinical level, very prevalent in the population, but we would only give a diagnosis of an actual specific phobia if that fear is getting in the way of your life. Okay? So I like to give myself an example. I am quite fearful of rats. I grew up in New York City. I'm not a big fan. There are a lot of them there. But if you ask me, does your fear of rats get in the way of your life? I would say, no, not really. I go to work. I see all my friends. I'm not worried about running into rats on a regular basis, right? If I decided to move from clinical research into mouse model research, I might have a problem, okay? And if my fear of mice got to the point that I actually couldn't do my job, then I would definitely qualify for a phobia, okay? So it's just another example of thinking when we have worries, that does not always mean that we qualify for an anxiety disorder. When we're talking about disorders, we're talking about worries that, again, are halting your life, getting in the way of your life, holding you back, as opposed to helping you navigate it. So these are kind of our traditional anxiety disorders. These are the things that you find in the DSM and that many clinicians will be familiar with. And just again, to give you some more illustrations of what this might look like in folks on the spectrum. Here we have Peter. I've been unemployed probably for 7 years with the global financial crisis and all that. And it's been hard for a lot of people to get work, not just me. And I hate volunteering. I mean, I need money to survive. So for me, what makes me anxious is just what will happen in the future, the uncertainty of it all, I guess. Has anybody ever had fears like this? Probably in recent history, okay? What we see here in Peter is another good illustration, right? That the traditional anxieties not only arise in autistic people, they arise in the general population, and sometimes they're very normative and very adaptive. And just because we see these fears in somebody who's also on the spectrum doesn't mean we want to over-pathologize them, right? We always want to think about these fears within the context of the individual's life and evaluate how they're actually related to the person's functioning. Okay. So you can see the importance of not only recognizing the worry, but again, just recognizing the context for the individual on and off the spectrum. Now, in addition to those classic worries and the classic conundrums that they raise about where to draw the lines between adaptive and maladaptive kind of fears, we also see examples in the literature about how even these more traditional forms of anxiety might also interact with autism. So Victoria describes her son. He's concerned about people smoking and that he's worried for their health because I've had to stop him saying smoking is a health hazard to them all the time. You know, because he was concerned. In fact, he lost a job because he was so upset that other people were smoking near him. Okay? So concern about the health and well-being of others is kind of a classic manifestation, again, of generalized anxiety. And we see that here, But we also see that those concerns potentially interacting with autistic characteristics, right? That is, we see the struggle to inhibit sharing those concerns with others and maybe sharing them in ways that are socially abrupt, unexpected, or possibly intrusive. And we see in this quote again the illustration of the effects of that anxiety, right? Which have in this case led Victoria's son to lose his job because he struggled to regulate his worry. So he struggled not to kind of express it to somebody else in the workplace. So just examples of what these traditional anxieties classically look like, how they can present in people on the spectrum, and how you can see ways that they might interact with kind of autistic characteristics. But beyond that, beyond the traditional anxieties, I just also want to take a little bit more of a moment to dig into what we mean by these different types of distinct anxiety that we see emerging in the research. And these are the anxieties, again, that do not neatly align with the categories and the diagnostic criteria laid out by the DSM, and which I've been illustrating kind of gradually through quotes. In our research, we've begun to see these themes. We've begun to recognize themes based on the qualities and the focus of these distinct fears, and we've given them names in order to kind of assess their frequency and just measure them. So here you can see the rates of different types of impairing distinct fears from our 2020 study. This was conducted in collaboration with the UC Davis Mind Institute in California, and it's a sample of autistic children that were recruited for the community with a broad range of cognitive and functional abilities. The rates here are very similar to those reported in our original 2014 study as well, which was also conducted in a community sample of autistic youth. So what you see is kind of the most common distinct fear manifestation is something that we like to call fear of change. So, fear of change is kind of what it sounds like. It's worrying about unexpected changes in routine or in the environment, the schedule, how things are done, dealing with novelty, okay? Importantly, it's not just having trouble coping when a change occurs. So because in these studies, we're looking for anxiety disorders, in order to give kind of an impairing fear of change fear in the studies, to classify as distinct anxiety, we very much insist that there's an anticipatory component. So the kids who meet criteria for fear of change in the research study are children who are not only having trouble dealing with changes when they occur, but they're asking repeatedly, worrying about if a change will happen. They're asking to see the schedule, to be reminded of the schedule. They're expressing worries about what if it's different? What if there is a substitute teacher today? What is my plan? What if it's an open-ended question, right? So it's very much anxiety. It's fearing something before it's actually occurred, as opposed to just reacting to it. It's also, notably, for many kids on the spectrum, something we see in the absence of more generalized anxiety. And I think this is an important point, because worrying about changes, novelty, newness, uncertainty also really goes hand in hand with generalized anxiety in the general population. But we see in some autistic children, 20 to 23% in the studies, is not those more generalized fears, but rather a very focused fear around changes. Okay. The next most common kind of distinct presentation that we see would be an uncommon phobia. So these are fears, and I'll have an illustration of this in the next slide, of very specific sights, sounds, the look of something, the feel of something, exposed pipes, gloves, black toilet seats was one of my clients, a specific song, okay? It's not loud sounds. Loud sounds is actually a fear that you see in a lot of kids. It's a very specific sound, the beep on the microwave, for example. So these uncommon phobias we see pretty regularly in the studies as well, in about 15% of the sample. Okay. Other social fear is the term we've used to describe the children that I started to kind of illustrate a bit before, who are very afraid in social situations. But if you talk to them and if you talk to their parents, they're not really focused on what other people think. Some are not tuned into that yet. They're not worried about it. That's not what it is about. It's more about kind of what people are going to do and not knowing what to expect from the situation and having difficulty predicting other people's social behavior and expectations. And this often goes hand in hand with some more social cognition challenges where theory of mind is more challenging. So thinking about what other people think about me may not be something that's fully online yet, but they are still extremely anxious in social situations. These kids don't meet full criteria for social anxiety disorder because social anxiety disorder is so centered around this fear of negative evaluation, and that is just not present for them. And by the way, this is not just in kids who have less verbal ability or who maybe are just not expressing their fear of negative evaluation yet. The first time I ever saw this was with a 17-year-old who had 150 IQ and very clearly explained to me that they were not worried about what other people thought or their opinions or their judgments about them. It was more about the unpredictability of the social situation or the difficulty of reading social cues. Okay? So this we call other social fear, so we can measure it separately from classic social anxiety disorder. And finally, the least prevalent kind of distinct presentation that we see across studies, but which has been there in every study I've done, is something called special interest fear. And these are anxieties that can arise around a focused interest or specialty that a child has. So if they're extremely interested in Mario or SpongeBob, it's not just the interest and how the interests may get in the way of them doing other things, it's the anxiety about the interest. And as an illustration of this, this might be a child that wakes up at 5 a.m. and is worried about if they're gonna have SpongeBob time after school that day at 6. And they are worried throughout the day, checking the schedule, seeing if we're late because they are worried that they might lose access to that thing that they enjoy so much. They're worried that somebody might mess with it while they're not there. They're worried that the iPad, if that's what they're very interested in, might lose power and not be chargeable. And it's the worries that are actually getting in the way, not just, I'm so focused on this thing, I don't want to do anything else. And I think you can, I'm going to hope that you can kind of take my word for it that we're measuring really the anxiety and not just the intensity of the interest, because the prevalence rate of this is really just around 5 to 7% in all the studies. I think if we were actually measuring focused interests, it would be much, much higher, right? So that's not what we're doing. We're not just measuring there being an intense specialty or interest. We're looking at the anxiety that in some kids can really become problematic and layered on top of it. Okay. Because this conference is particularly focused on sensory sensitivities and anxiety, I wanted to take a moment to talk a little bit more about these uncommon phobias and sensory sensitivities and phobias in general. I have a fear of mushrooms. If you whip one out, I start the physical sensation of fear, but it wouldn't bother me. There isn't an accompanying anxious thought. I wouldn't be like, oh no, mushroom is dangerous. It just makes me feel pain. So you see autistic individuals and their caregivers often talking about panic or physical sensations of fear, but not necessarily cognitive worries. A parent describes, H becomes extremely anxious when he hears a baby cry. He's got a radar for 700 miles. If she moved the cucumber near H, he's heaving, panicking, okay? So I put these quotes up here because I think they illustrate quite well how complicated and confusing this can get, right? So we're having descriptions of panic, of the physical sensation of fear, but certainly there's also a question of, is this sensory sensitivity? Is there something that feels aversive and thus is, of course, causing a negative reaction? Is it food selectivity? Is it all of the above, right? You can see how they all get intertwined. And what I want to note is when you look at these studies and you see that we've given a diagnosis of phobia, we really require, again, some illustration of an anxiety component. So a fear of this thing before it's directly in front of you that's getting in the way of your life, not just an aversive reaction, okay? So for example, being afraid to go into doctor's offices because there might be a TV in the waiting room and they might have a cartoon on with poppy eyes, okay? Right? If you're afraid of kind of cartoon eyes. Being totally scared to go into a store where there might be toys because there might be mechanical toys that are moving, if the mechanical toy is what's frightening, okay? We see these for these distinctive kind of phobias, but you also often see this overlap or entanglement of sensory sensitivity and phobia for things like loud sounds, right? So a lot of kids on the spectrum, adults on the spectrum, you might see when there's a loud sound, cover their ears. They need to get out of that situation. It's very, very aversive for them. In order to give a phobia of a loud sound, what we are looking for is the child who can't go into a bathroom and might even have an accident because they're afraid there might be flushes or loud sounds or those dryers in the bathroom, right? A client of mine, whenever they went to a new place, had to kind of case the joint for where all the fire alarms were. They were worried about there might be a fire alarm that's going to go off. Kids who are afraid of loud sounds might also be checking in with the teacher constantly all day. Is there going to be a fire alarm today? Is there going to be a fire alarm today, right? And they have trouble paying attention in class because they're so worried it might happen, okay? And that's the anxiety that we're looking for that's getting in the way. It's not just the painful reaction to the sensory experience itself, okay? And I just want to point out, too, that the way we're assessing this quite carefully, I'm hoping I'm making apparent, is by using a semi-structured diagnostic interview called the Anxiety Disorders Interview Schedule with an Autism Spectrum Addendum. And it's a classic anxiety disorders interview that we've adapted particularly for youth on the spectrum to do kind of two key things. One, to give clinicians a systematic way to kind of weave through or parse out these overlapping features and to try and pick out what might be characteristics of autism from the anxiety that might get layered on top. So figuring out what the social avoidance is about, figuring out if there's sensitivity, sensory sensitivity, and also a fear layered on top of it. Figuring out if there's just kind of a focused way of thinking that might look a lot like generalized anxiety, but is not. It's not just about worries, it's just kind of about getting focused on topics in general. So the interview gives clinicians a systematic way to sort through these kind of conundrums or difficulties. And the other thing it does is it expressly queries for these distinct expressions of anxiety that we've learned about through years of research, so we can, again, capture them and measure them in a reliable, valid way. And I just want to let you know that kind of across the studies, we've looked at the reliability and validity of this tool, and we have found consistently that we can establish good inter-rater reliability, so good agreement between clinicians. A clinician can do an interview, another clinician can listen to that interview without knowing the first clinician's scores, and they can come to very high agreement about what the diagnosis should be for both traditional anxieties and these distinct expressions. We also see good kind of convergent validity for traditional anxiety disorders. So the traditional anxiety disorders as assessed by this interview, if you find them on the interview, they're very likely to also be picked up on another measure of anxiety. This is less the case for the distinct anxiety presentations. And again, that's because for the most part, those things are not asked about in traditional interviews that were not designed for kids on the spectrum, okay? But we do see very good reliability for them. I just don't know if we have a tool to assess convergent validity yet, although it's coming. Okay. So that was my little divergence tangent about what these things actually are. Now I just want to get back to the data a little bit more to tell you again just what we keep learning. So we applied this approach to better understand anxiety presentations of autistic children to kids that were treated in one of the largest clinical trials of CBT for anxiety to date. And what we learned from this trial was that the vast majority of kids met criteria for a traditional anxiety disorder. So only 2%, this is the light blue segment on the screen, had solely a distinct anxiety presentation. However, 50% of children meeting criteria for a traditional anxiety disorder also had interfering distinct fears. So what this means is that distinct anxieties may be very common in autistic children receiving CBT, even if they weren't the fears that got them into treatment. It also suggests that children with only distinct presentations may be less frequently recognized as experiencing anxiety and requiring anxiety treatment. Whether this holds true in community treatment settings requires further study. So this is a randomized clinical trial run by researchers, right? It's not the same thing as looking at a community clinic, so we really need to do that research. But I think these initial findings provide strong rationale for better understanding these distinct fears, their role in autistic children's clinical presentation, and their expected treatment response. So research also suggests that carefully considering the presentation of anxiety disorders may shed light on how intellectual ability relates to anxiety in autism. So in this study from 2020, we found similar rates of children with and without intellectual impairments presenting with impairing traditional and distinct anxieties, okay? So whether or not you have co-occurring intellectual disability, there's a similar likelihood that a child would meet criteria for an impairing distinct presentation or some kind of traditional anxiety, okay? However, when we looked at the types of anxiety disorders being reported across groups, differences emerged. Specifically, the anxiety of children with intellectual impairments was primarily comprised of specific phobias. Things like fears of dogs, dentists, heights, loud sounds, and also of distinct anxieties. So this is meaningful as it suggests that the cognitive abilities are related to the expression of a child's anxiety disorder more so than the likelihood that they will have one. Okay. It also offers some insight into why studies suggest that brief anxiety questionnaires that were developed and normed on non-autistic samples have diminished accuracy in autistic youth. The traditional anxiety presentations these measures screen for reflect just one part of the picture for autistic youth, and it's a particularly small part for autistic youth with co-occurring intellectual disability. So it's not giving us the complete picture. Our research also has supported the hypothesis that traditional and distinct anxieties have both shared and unique features or associated characteristics, which might help explain why findings regarding common indicators of anxiety in the broader literature are often inconsistent across studies. In our 2014 study of 59 youth on the spectrum, which were again recruited through community settings, we found that whereas children with greater language skills, more sensory sensitivity, and kind of an anxious cognitive style, so an anxious way of looking at the world, they were significantly more likely to have traditional anxieties. The things that predicted distinct anxiety were, again, that anxious cognitive style and more autistic traits, as measured by the social responsiveness scale. That is consistent with kind of our clinical conceptualization and observations. Distinct anxiety may reflect the confluence of anxiety and autistic characteristics. IQ was not related to distinct anxiety in this study, the way it was when we saw in 2020. But interestingly, it wasn't related to distinct anxiety, and that was also true in the 2020 study. Let me correct myself. And I think this just underscores the point that distinct anxiety is not just traditional anxiety disorders in children with lower cognitive abilities or a lower developmental level. We really see these distinct expressions in children with a full range of cognitive abilities. It's not just traditional anxiety that's being expressed in slightly a different way because the words can't come out. And to that point, I want to note that IQ was also not related to traditional anxiety in this study, but But part of the reason this was the case is because we also controlled for language ability in the model, okay? So what you see here is what's really predictive of traditional anxiety that's often also probably associated with IQ in other studies that don't measure language is your verbal expression. And this is somewhat intuitive, because if you think about generalized worries and social anxiety, fear of negative evaluation, there's a real component of being able to express, I am anxious about this. What if this happens, right? Very, very hard to diagnose those in kids who are not able to verbally communicate in that way. And that's why we might see more traditional anxieties like phobic responses or separation anxiety that are just more observable behaviorally, okay? And finally, this is a recent study in 2022, also coming from our collaboration with the UC Davis Mind Institute. By taking the time to assess and differentiate traditional and distinct presentations of anxiety, we've also learned that they are associated with significant differences in the volume of the amygdala, which is the brain's fear processing center, albeit in disparate ways. So specifically, a recent study found that youth with only DSM anxiety, so traditional anxiety, had significantly larger amygdala volumes, which is the top red line in this depiction, whereas those with only distinct anxiety had smaller amygdala volumes relative to one another and to autistic or non-autistic children. So this is a first study. It's a small sample. It absolutely needs to be replicated before we make too much of the findings. Nonetheless, the findings are certainly intriguing, right? That this thing that we've seen clinically and behaviorally that we've learned how to measure reliably is associated with differences in the amygdala, but in very distinct ways. So limitations and future studies. I want to point out all of this research that I've just presented to you, unfortunately, does not have the most diverse sampling. So the samples are really limited to children. We do not have data on these distinct expressions in adults yet, except many of the illustrations I've given you from the qualitative work, okay? So it would really be exciting and important, I think, to start doing this work in adults on the spectrum, and I think we actually would learn a lot more about these anxieties by doing so. I also want to point out that these samples are really predominantly mostly white and male. This is also starting to change, and actually for anybody who's going to be at INSAR next week, Dr. Christine Nordahl will be presenting some new research about looking at different presentations of anxiety in males and females on the spectrum. But that's certainly a limitation, and it means this is the first step, and we have a lot left to learn. The other thing I want to note is that with the exception of our 2014 study, which was the first one we did with this adapted interview, the interview is based on parent reports. So these are lengthy, detailed interviews with parents, trying to get a real understanding from them about what the child's dealing with, what situations are frightening to them. We spend a minimum of an hour and a half, sometimes to 3 hours with the parents in order to get to the bottom of these things. But in the future, we really would prefer to do a combined parent and youth interview, meaning that we're not only interviewing parents about the anxieties that they're seeing in their children, but we're also able to talk to the children themselves when they're able, and teens. And we know just best practices that multi-informant work like that is the best way to go. And it will be, I think, bring further rigor and information to the work. And just as an illustration of this, in general, when you talk to parents of a teen and the teen themselves, they have different opinions about things. And usually you can't get the whole picture unless you talk to both of them, right? So that is the direction we'd like to move towards, but the work has focused on developing the parent interview first, just because we do know that for some folks on the spectrum, the ability to engage in an interview or self-report is not something that's easily accessible to them. So we are reliant to talking to parents. I think another important direction is response to intervention. So again, we know that these distinct presentations are quite common in kids who are getting CBT treatment. We need to look carefully at if they respond to CBT in the same way. and this is also something that we're actively working on, or if they're more likely, for example, to respond to that adapted autism-tailored CBT approach more so than a standard one. We also need to better understand the underlying mechanisms, so the role of sensory processing differences, the role of adversity and traumatic experiences. These are both things that I'm interested in. We have a lot more work to move them from just theory and hypothesis to actually some data. And finally, dissemination and implementation, right, which is thinking about how do we train providers in the community to recognize these different expressions of anxiety so they actually get recognized as anxiety and potentially treated and the kids can get supported with it. Okay. Connor wrote of Alfred in his original case series, he had a good deal of worrying. He frets when the bread is put in the oven to be made into toast and is afraid it will get burned and be hurt. He is upset when the sun sets. He is upset because the moon does not always appear in the sky at night. To address the challenges of anxiety in autism, we must begin by better recognizing and understanding these distinct expressions of anxiety. Thus far, our research suggests they are prevalent and impairing for autistic individuals. They are likely under-recognized and under-treated in this population, and adding considerable variability or noise to research seeking to characterize not only anxiety in autism, but autism itself, if not assessed. And I'd like to turn over to questions. Any questions?
Any questions? Thanks, Ryan. How can you tell in a female if they have social anxiety versus high-functioning autism spectrum disorder?
There's a question of versus and also of both, I think is the takeaway. So, for social anxiety, I would start assessing for the characteristics of both conditions. So social anxiety would be fear of being negatively judged by others, rejected, feeling really shaky in social situations, a variety, having trouble even leaving your voice on a voice message or calling someone or eating in front of people, writing in front of other people because you might make a mistake. So there are a lot of specific fears. And what we would want to assess, if you think autism is also in play, is if those fears are excessive even given the social adversity that's been experienced. So for example, in the diagnostic interviews, we always extensively query about the level of bullying that's been experienced, past and present, in order to have a good sense of if the fears are actually very adaptive and related to negative evaluation currently happening. Mm-hmm. Or if, which would be characteristic of anxiety disorder, they've become overgeneralized, okay? So maybe they did have a very bad experience in the past, but now there's a complete terror or fear of going into any social situation, including potentially into a support group, where there might be a lot of like-minded individuals who could really help the individual. But the anxiety is so intense that you can't even get through the door, okay? So that's how we're looking for it. And that's quite separate, I think, from assessing autism spectrum disorder, which I traditionally conceptualize as a neurodevelopmental condition that's associated with social communication difficulties, and from early on in life, even if they're not immediately recognized, as well as kind of repetitive and restricted behaviors or characteristics. And of course, you have to look at camouflaging, right, and masking, but the presence of those things would, I think, be separate from social anxiety, and what you're really doing is not trying to say one or the other, or is there presence for this as well as this, because sometimes it's often both.
Right. Thank you. We had, in relation to that point and that question, Dory Ziener was here recently to talk about girls and women specifically, and Dory has been to presentations here in the past. We've had permission to record day one, which we have, and it will be going up on our website in the coming weeks. So encourage whoever asked this question to have a look at those materials for some additional information. Thank you. That's great.
I would say also that for people with social anxiety, when they're in situations where they are more familiar with people and feel more comfortable, you can see a real shift in their comfort level and their reciprocity and their nonverbal communication, et cetera. So there's quite a stark contrast between how they might feel and being quite shut down in terms of anxiety in unfamiliar social settings versus when that fear is taken away, that I would not think is as associated with autism.
Thank you, Connor. Next question, specifically related to your assessment measure, which I am really looking forward to seeing more about. What is the age range for that?
So we've tested it, it's just for children right now. We've tested it in preschoolers up to kind of 17, 18-year-olds and found good reliability. The validity in terms of convergent and discriminant validity, we've tested more in the 7 to 18-year-old range. But yeah, we recently did a study of preschoolers with Kennedy Krieger and found good inter-rater reliability in the 3 to 6-year-old range as well, even with some kids with more significant developmental delays as well as being young.
Great.
It takes some training, however. It's not just something you can pick up and do with great accuracy. As you can tell, there's a lot of it's semi-structured. So there's follow-up interviews, and there is a training component in order to, I think, execute it accurately.
Great. And this third question is also related to that measure, but you've answered some of their question. But the other component of this would relate to measuring anxiety in children that have a high likelihood of later having an autism diagnosis. So those kids in that early age stage before it's even potentially diagnosed.
And the question
recommendations for what you might use to measure that anxiety.
I think if autism is a question, that probably this adapted interview will be useful. And so I would probably recommend it. I think for kids who are not on the spectrum, the original ADIS is more comprehensive and extremely well validated for that group, and some of these additional questions may not seem very necessary or as applicable. So, but if there's any question of autism, if that's something you're thinking about, differential diagnosis, I think this would probably be helpful.
Right.
I do also want to know with the interview, it's quite time intensive. That's why I feel good about our results. It needs to be done by a trained clinician. There are other folks who are working on brief questionnaires adapted for people on the spectrum that are probably easier to use widely, and they're shorter. So things like the PRAS-ASD, which Larry Scahill has developed, or the Ask-ASD, these are developed by Jackie Rogers in the UK. These are both brief, more kind of screening measures or scales that a parent and youth could just fill out themselves that are also more adapted to this population, and they get at some of these distinct expressions, albeit not in the same level of detail as we do in the interview. So those are just important options to be aware of as well.
Thank you. Any questions? Yes, I'll come up to you. Excuse me. Thank you.
I just had a question about the assessment. Is there a teacher portion? Because our kiddos present so differently in school, surrounded by, the stuff they don't want to do and non-preferred interests, blah, blah, blah. Just wondering about that.
There is not a specific interview for teachers, so it's mostly with parents and then hopefully with the youth in the future. We do spend a lot of time at trying to ask parents, like, what's going on at school? Have you been talking to the teachers? What do the teachers tell you? So we try and get at it that way. But I think, again, best practice is probably to have an interview like this, some questionnaires that are filled out by teachers, by parents, and by the youth themselves, and then to combine all this information in order to make your final decision. That would be kind of my recommendation. I feel like it would be fantastic to do this interview with teachers, but as I mentioned, it takes a minimum of 2 hours usually, and I don't know if teachers have that much time because they're very busy and have lots of students. So I think there might be a feasibility issue there. But again, this is where I think these questionnaires are quite important because it really is important to get information from multiple sources to have a good holistic view of what the behaviors are in different environments and to assess kind of parents' judgment. But right now, we're relying a lot on parents and asking very detailed questions about what's happening at home, what's happening on the playground, what's happening at school, what have you heard from school, et cetera, in order to try and get that.
And I know there's a couple of school psychologists or former school psychologists who are in the room who are probably thinking, but we could get trained on that, right, Corey? Ken? So teachers might not have the time, but that might be a future direction. I'm just thinking about their role as a member of school-based team, and they're conducting psych-ed assessments. And I know that in Surrey there is an autism diagnostic team as well.
Yeah, I think that's a fantastic suggestion because the school psychologist would have observations and information from the teacher in the home setting, but then have this detailed way to also talk with parent to kind of what's going on and potentially to interview the child as we move in that direction. So it's a great suggestion.
Why do researchers start with such a limited group, i.e. white, male, rather than with a more diverse group?
We're trying to make this much better. Some of these studies are going back to 2015. Honestly, there's a research reason in terms of, for example, restricting age or wanting to ensure that everybody in the research study has a certain level of autism characteristics. And that can be just to reduce heterogeneity in the sample in order to actually find something and understand, we found this is true for this subgroup of people on the spectrum, and we can characterize that subgroup, and now we need to understand that we need to study it in other subgroups, right? So that's a research reason, but that is not an excuse for all male and white. I think that is just more a function of what the feasibility has been. And it's also, I should mention, a lot of, it's not quite as bad as the disparities in terms of racial and gender, but a lot of the families in some of these early studies also have, the majority have post-secondary education, and there is some distribution in terms of income, but we could do a lot better in terms of just pulling from underrepresented groups. And I think there's been a real shift in research to in research grants and just the priorities of the researchers say, we understand that it's harder to engage those populations in research, but we need grant funding to do that, and we are very serious about it, and this data is not really worthwhile if we don't do so. So I think you're going to start to see those shifts, but part of the reason why you've only seen a lot of white males is because that was the easier to get population for a long time, and there wasn't this kind of true grappling with how important it is to not just work with the easier to get sample, and that we really need to represent the full spectrum. I also think we are seeing a shift in terms of the number of girls who are even being recognized in the past decade, and that is going to change a lot of what we understand about autism itself. So that's also a possibility that I think we'll be grappling with. Yeah.
And I'm thinking about potential partnerships with school districts. So I think about Surrey. So when I left Surrey 6 months ago, we had about 2,400 kids with autism diagnoses, K to 12, and almost 200 languages spoken. So I think, you and I were chatting earlier about communities of practice, and I think the more that we can have universities that are reaching out to diverse school districts like Vancouver and Surrey to sort of partner on those initiatives, I think would go really well to creating that diversity.
My lab is very interested in that.
Wonderful.
Yes.
I know some people.
Okay, excellent. I would really like to present data on not just people from one gender and one demographic. That would be great for the future.
Awesome. Another question relating to the credentials and specific training for your assessment measure. So
I have trained graduate students in this very successfully, so you don't need a PhD, you don't need to be a doctor necessarily. However, you probably need to be supervised by somebody who's familiar with giving diagnoses, and because it is a diagnostic measure. So in terms of who can do this, you need to have training in child diagnosis. However, we can definitely have kind of psychometricians being supervised by clinical psychologists or other diagnosticians to do the work, and they can get trained very reliably. I've been able to train very successfully a number of people remotely also, and the training kind of consists of an initial introductory session. It's about 3 hours, and then we have a series of training tapes. We actually listen, code, we do group supervision, we try and create a mind meld, talk about it, and then in order to get kind of signed off, I ask that clinicians send a recording of their own interview, which I check for reliability. This is what we've done in the research studies, and there's a higher standard for research reliability than for clinicians, similar to an ADOS kind of training, and so that's how we're operating right now. Right. But I do think that training is important because it's not a structured interview. You don't just read the questions. It is a semi-structured interview, and it very much involves having an understanding of child development and a good understanding of kind of this is anxiety, this is autism, and here's where they're not too distinct.
Right. Thank you. The last question, Patrick, you've got a question. Go for it. Was that your hand up?
Yeah.
Perfect. I'm coming. No worries.
It's kind of just a follow-up on what you were just saying there about the training. I'm curious if you have tried to train any autistic people to use this measure, because the ADOS analogy you brought up, it reminded me there's actually this really interesting piece in Autonomy, a journal from the UK, talking about the ADOS and how this group of, including some autistic people, they were having somewhat different ideas in the ADOS training from, the ideas they were supposed to have. It was quite interesting, and I wonder if that would actually give you some interesting insights into some of these experiences if you found that, autistic and non-autistic people were interpreting things differently in the training.
Yeah, I think that would be fantastic. Nobody has self-disclosed to me that they're on the spectrum that I've trained as of yet, so I don't know. But I think that would be a really important future direction, and I'm very, very open and think it would be, a lot of this work has to do with what we've heard from autistic individuals, just telling us what they're dealing with and what makes them feel afraid and what that feeling is like. And I'm very invested in trying to accurately reflect that in the clinical measures in order to make things better and actually support this population, and figuring out, how to effectively treat as well, because understanding the source of someone's anxiety and what's actually driving the fears, I think is really fundamental to helping them learn to cope with those fears. So I would hope that it's not going to be a total shocker, but I feel like you're absolutely right. We're not really going to know until we train somebody on the spectrum to do the interview, and then could get that perspective would be fantastic.
I think that's a further conversation to have at INSAR. So Patrick, I believe you lead a group of autistic researchers that will be meeting there?
I don't lead it anymore. There are new leaders, but it exists.
Perfect. I think it exists thanks to you, though. Am I correct?
I co-founded it with TC, also in Vancouver somewhere.
Awesome. Okay, thank you. And then the last question, which I think is a biggie.
Oh boy.
It's a biggie. I think it's, how to stop dog anxiety and fear. So you mentioned earlier children and youth that might be anticipating that experience, not going outside because they're afraid that they might encounter a dog, for example. So I know that this is a very specific question, and it might be beyond the scope, but feel free to.
Yeah, so cognitive behavioral therapy is actually a pretty effective approach, and I think an adapted program can be, it depends on the particular characteristics of the child that we're talking about, how severe the anxiety is. Sometimes the anxiety is so bad you can't leave your home. And for other kids, they're still able to do a number of things. But CBT is very likely to be effective. I'm not saying the anxiety will completely go away. So I think that's something we see in a lot of the studies as well, is technically there's definitely improvement in anxiety, but it doesn't mean like anxiety is entirely gone. But there's much better kind of coping skills and ability to function despite the anxieties there. And what that would look like, just a basic way of kind of describing what CBT is like, is learning how to recognize your anxiety, ideally before it gets to 100, so more when the train's rolling out of the station as opposed to going 100 miles an hour, because it's easier to stop the train when it's starting to go going as opposed to when it's full speed. So recognizing anxiety, having words for that, predicting what situations that might come up, and then figuring out what to do about it. So what are coping skills that you have that you can actually use to kind of bring the anxiety level down? And CBT tries to target that in 3 specific ways. You know, one is what you tell yourself. So if you're thinking that dog's gonna bite me, you're probably gonna run away. If you're thinking, oh, maybe that dog will ignore me, it might be okay. Or even for young kids, I can get through this, I'll be okay, my mom's with me. You know, that kind of just a basic coping thought can be helpful. But for some folks, it's more about bringing your actual arousal level down. So doing something like taking a deep breath, distracting your body, just doing something to reduce the intensity of anxiety can actually help you think clearer and behave differently. And for some folks, it's just gradually starting to do the thing. An example of how we might do dogs, I mean, we've actually done a lot of dogs. So usually start with like a video of a dog jumping on somebody, or maybe like the dog park, and we're over here and the dog park's over there, and we gradually get closer, and then maybe someday we walk by a very sedate older dog that's small, and then maybe a small dog that's not so sedate. And usually the final exposure for my kiddos would be for them to meet my 80-pound Airedale, who's quite jumpy, but is really good at sit. So my favorite exposure to do with kids with a dog phobia is to have the Airedale, they say come, and he runs at them full speed and then does like a sit right in front of them, because they are facing their fear, but they're also very much in control of the situation. So this is a long answer to CBT is about recognizing anxiety, figuring out what you can do about it, and then gradually using those skills to start to approach the things that make you afraid. And it is slowly, so you're developing mastery and you're feeling in control of the situation, which is very different, for example, than just being thrown at a dog or pushed off a diving board if you're afraid of the water. It's very important that the child is making the decision to take the step towards the fear. That's what I think has a big impact on therapeutic change. So long answer, but I think those are pretty good strategies for dealing with dog phobias.
Thank you so much. So we're a little bit over time.
Can I say just one thing? I just wanted to acknowledge my lab. So the Anxiety, Stress, and Autism program is our research program that's focused on anxiety and trauma in folks on the spectrum at UBC. These are my wonderful graduate students. And I wanted to say that if you're interested in anxiety, we have resource packets specifically trying to disseminate evidence-based materials to the public about what we know about anxiety in folks on the spectrum, how to assess it and how to treat it, that are available on our website. And we are also trying to do kind of a quarterly speaker series where we directly disseminate the research to the community, so we can give back immediately.
Great.
That's it.
Grace.
Yeah, one last question.
Yes.
Connor, what do you think about virtual reality approaches to treating anxiety? Any?
I don't know. I haven't done them at all.
Okay.
I will just not dig myself into a hole by answering that question because I actually know nothing about it, unfortunately.
Okay. Hypothetically, it sounds like it could work. But I don't know.
Again, I haven't gone deeply into this literature, but I think there are at least a few studies published that suggest that it is helpful. And I have never done virtual reality, but definitely have used things like videos and imaginal exposure for a long time, right? And imaginal exposure is basically when you imagine yourself in the situation and walk through it and even write a story and go over it over and over and over again just to bring the anxiety down around that before you actually do the real thing. So just based on all that, I could definitely see the likelihood that virtual reality could be really useful, but I haven't done it, and so I don't know much about it. Yeah.
Okay. Thanks.
I have a couple papers in my bag here.
Oh, there you
Yeah, on that exact subject.
Great.
Great, expert in the audience.
I was going to ask if we had any budding researchers here that might want to take that on for a dissertation, so thank you for that. Okay, so I purposely jumped right in and announced you without any fanfare because I knew that we had limited time to hear your amazing work and to hear about the assessment measure that you're working on. And so all of the questions really, I think, underscore the importance of that and the interest in that and enthusiasm. Thank you for giving us such an engaging presentation this morning.